Dr. Rajesh will be talking about the different injector system and other tips in Dmek procedure.
Good afternoon, everybody. At the outset, I would like to thank Dr. Basak for including me in this course. He has been doing this course for a long time and covering a very important aspect of Dmek surgery, which is currently the preferred technique of doing endothelial keratoplasty. How many people in the audience doing Dmek? Okay, we do have some. So I think some of these points have already been covered. So to insert the donor, you basically need an injector. You can use a dedicated glass injector or an endoglide, or you can use even an IOL cartridge to insert the donor DM scroll. Now, you can see that these are various donor delivery devices that can be created. You can use a Alcon cartridge or a sensor cartridge or a micropipette or even a glass injector. This is the one that's made from Georgia Surgical. And I'm sure Dr. Basak is aware. I think you still use your IOL cartridge only with attached to that Simcoe cannula. So he's been very innovative and he's very economical as well. So it's basically a fluid-based flushing system that you flush the DM scroll into the eye. You're not pushing it like what you push an IOL. And so all these videos are there on YouTube. You can look up the exact execution of the insertion. So when you load the donor, you have prepared the scroll. You can load it directly from the corneoscleral rim. But remember, you have to ask your nurse to keep replenishing that fluid in the, otherwise you run out of fluid and your scroll is not yet gone into the cartridge. Or you can transfer the DM scroll into a bowl and you can then aspirate. You have adequate amount of fluid. This is loading from the tip. The other way is to load from the posterior end, which is the wider end. So this is good, especially for scrolls that don't scroll up. You have a scroll that's remaining open. If you try to aspirate through the narrow tip, sometimes there can be a shearing at the tip of the edge of the cartridge. Whereas here, because the opening is larger, it goes in much more gently. Or you can do this process where you can just catch the scroll at one end, lift it up, and you can gently, pass it into the injector system either from behind or from the tip. By capillary action, it just goes in, and so there are different techniques of doing it. You can practice in the wet lab, and whichever works for you, you can use it in your clinical practice. Now, I think Namrata also showed you a situation where you have the scroll jumping out of the eye. This is undesirable because as you inject the fluid to push the donor into the eye, the AC gets filled with BSS, and sometimes, especially if the anterior chamber depth is not adequate, you will have the AC becoming pressurized, and then when you push your donor in, you can have, as soon as you remove the tip of your injector, you find that there is a tendency for the donor scroll to try and jump out of the eye. That's why you need to release fluid from the side port to try and soften the eye so that the counter pressure is minimized and you can safely release the tip. Also, before you inject your donor into the eye, try to identify the orientation of the scroll by looking at this tip where you see that V. That means the open end of the scroll should be facing towards the surgeon and not towards the iris. So when you insert it like that, you are inserting the donor in the right orientation. So thereby, the job of unfolding becomes easier. Otherwise, you unfold it, you realize it's upside down, and then you again have to spend time to try and flip it over. So this is when you have the biceps curl or the the open end of the scroll facing towards you, that's the right orientation. Now here you can see that when you're trying to insert, and if there is increased fluid pressure, the tissue, and this also happens when your speculum is very tight or you have given a peribulbar block and there is too much of external pressure. So that upthrust also causes the AC to shallow, or you have made a wound that's larger than the tip of your injector. So sizing is very important. If you oversize your wound, the fluid leaks from the side and you have the tissue trying to come out from the side. If you undersize, then what happens is you manage to get your tip inside the eye, but when you're trying to remove it, you find that the tip of the cartridge is kind of stuck in the wound, and then you manipulate and it suddenly comes out, and then the egress of fluid brings the donor back out onto the conjunctiva. So these are the various configurations that's there on this website called patientready.org by Peter Wellman. So when you just push your graft into the eye, the donor scroll goes into the eye, and depending on the turbulence of the fluid, it can end up with any of these configurations that you have. But ideally what we want is we want a double scroll or a single open scroll with the open part of the scroll facing towards you. When you have that open scroll, single scroll on top of you, you secure the wound first, because while tapping you don't want fluid to get out of the main wound and the donor tissue to go out. So secure the wound and then keep the AC slightly shallow. I use two cannulas, one cannula to kind of fixate one edge of the donor and the other one to tap either inside, outside, or you release fluid from the side port. These are the three basic mechanisms. So if you have a fluid filled chamber and you have a scroll that's like that, if you have a paracentesis on that side, when you release fluid from the paracentesis, this part of the scroll will open up like that because it follows the fluid. Or if your scroll is like that, if you tap internally, then that fluid wave that goes out also carries the scroll to open up. And it doesn't scroll back because your chamber is not fully, if you have a deep AC and then you open it up because there is enough space, it will keep going back like this. But if you have a shallow chamber, partially formed chamber, then when you tap, the fluid is able to push it back, but then because there is not enough space, it cannot spring back into position. So same thing you do when you are tapping outside. When you tap outside, you move the fluid column away, but when the fluid column comes back, it takes this and tries to open it up. So here you can see you have like a taco fold. So if you have a taco fold, you give a short burst of fluid through the side port. Just to move this fold, which is like that, you make it like this. So the direction of the fluid is not towards the donor tissue, but below towards the iris. So you want to create a turbulence in the iris. So just give a short burst, and that moves this taco to the straight, and then you can use the same principles to open. This is slightly, if you have a tighter scroll or a younger scroll, then you use the drum roll technique or the Dirisammer maneuver, where you kind of pin down one edge of the DM scroll, and then using the second one and like a carpet unrolling maneuver, you kind of continuously tap from inside outside and you can get the scroll to open up. If you have a vitrectomized eye or an eye with a deep anterior chamber or a high myopic eye, you can use an air bubble on top of the scroll. That means within the scroll you can put a small air bubble and then use that air bubble to manipulate to get the scroll to open up. But remember, once the scroll is open up, you remove that air bubble very gradually, because if you remove it quickly, again the scroll will go to its original position. You do that even without removing the air bubble. You can straight away go and put an air bubble below, and the air bubble on top will move to the side, but sometimes that can affect your centration of the DM scroll. There is a technique, or the endo-in technique, which Donald Tan likes using with the endoglide. Even Massimo Bushin had shown this technique with a contact lens. So here you are basically physically folding the graft endothelium inside like a DSEC graft. And this can then be transferred onto a IOL cartridge. So the endothelium is not on the outside like a conventional scroll, but the endothelium is on the inside. And then you can use a microforceps to bring the tip of the DM scroll forward. And then you can see that you can pull the scroll into the eye just like you do with the DSEC graft, but don't let go. And then you can tap on the surface and the scroll. Now the scroll is like that, and you're opening up the scroll, and then you put an air bubble in between the scroll, and you can get the scroll to open up and put an air bubble. This is good for cases where, like this case had an AC IOL, or you have a shallow chamber peripheral synechia you have released, where if you put in the scroll upside down, you don't have space to re-scroll it, because then you won't be able to deepen the chamber. So in those kind of scenarios, this is good. If not, then you straight away do a ultra thin DSEC. It will work the same way. So that's the same patient with the endo-in pull-through technique, and you can see that the patient does very well. This is another patient. This is the kind of outcome that you see when you do a Dmek. Now, can you get this double scroll consistently? Yes, in about 70 to 80% of eyes, by moving the column of fluid between the narrow and the wider part, you can get the scroll. The scroll is tight when it's in the narrow part. When you push fluid to the wider part, the scroll opens up, and then when it re-scrolls, it can go into a double scroll configuration. So that way, by moving the fluid, by agitating the fluid, you can achieve a double scroll configuration in about 85% of the eyes, depending on the age of the donor. If you have older donors, they don't have that elasticity, so it will not spontaneously go into a double scroll. And if you use very young donor, that is such a tight scroll that sometimes the opening that you see between the narrow and wider part, it doesn't open up. There is another technique described where you take the tissue, when you are putting it in the Petri dish, you hold the tissue in the center at one edge, and then you just move the tissue in the Petri dish, and you will find the two edges away from the place where you hold, that goes into a double scroll. So these are ways and means where you can try and create a double scroll before you aspirate into the injector. The other thing that I do in my practice is I use an AC maintainer. The role of AC maintainer is that you connect an AC maintainer through one of the side port. This side port should be on either, it can be on either side of the main incision. Don't put it at 6 o'clock, because then the flow of fluid will take the donor scroll towards the AC maintainer. Now, when you keep the AC maintainer on, the anterior chamber remains deep. So now when you're trying to push your tip of the cartridge into the eye, you don't have the iris getting engaged. So you can safely put your tip of the cartridge inside, and then you can rotate it in a way that your open end of the scroll is facing up. At that point of time, you ask your nurse to stop the AC maintainer, and then she can disconnect it from the IV tubing. Now, when you have an AC maintainer that's inserted into the eye, the other end is disconnected. What it does, it allows fluid to leak out from the anterior chamber. So then, at that point of time, you push your scroll into the eye. So what happens is, there is no counter resistance, so the fluid flow is easier. Your scroll goes into the eye without too much of resistance, and once it goes into the eye, the chamber does not remain deep because you have fluid leaking out from the AC maintainer. So your chamber shallows. So what happens is the inferior iris and the cornea will catch your donor tissue. So when you are removing the tip of the cartridge, you won't have the tissue trying to jump out. So that's the advantage of doing it, and you can see that in this video that we have that. You can see the scroll goes in very easily, and I'm removing the tip of the cartridge from the eye, and you can see that the cornea is dimpling down. There is no tendency for the scroll to open up. We put in a suture, slightly form the chamber because the chamber is shallow. It's a double scroll, and you can see I'm just holding it in the center, and if I tap on either side, I release some fluid. You can see the scroll opens up, tap outside. This is already open. Once this is open, you can tap on one side to move the graft, and then again release a little bit of fluid so that it doesn't come back. And then you can, so this is again very important. Once your tissue reaches the desired position, the lifting of the cannula should be very slow. If you lift it too quickly, the movement of fluid column will again bring the graft back. And you can see now you can go and tap on the other side, your scroll is already open. So this video is actually in real time, it's not been edited, so it hardly takes a minute or two for unfolding the DM scroll. You can see another video, again the same. We put in the tip of the cartridge into the eye, rotate, so the open end of the scroll is facing towards the surgeon. At this point of time, AC maintainer is disconnected, but see how easily the scroll goes into the eye without any tendency for the scroll to open up. And as you just tap on the surface, you can see the scroll is opening up, one edge is already open. You move it to one side to create space on the other side. Then you fixate this edge. You can tap on the inside or the outside, and you can get the scroll to open up, and put a small air bubble first and then enlarge it to complete the air fill. And this is very reproducible. I can show you various videos how it works the same way. So this is like the go-to technique of insertion and unfolding that we do at this point of time. Sometimes if you have a deep chamber, as you are inserting with the continuous turbulence of fluid, you can have the scroll getting upside down, give a short burst of fluid, and you can get the scroll to open up. But remember, if you inject more fluid here, it scrolled, but then as the fluid movement continued, it went back into the upside position. So you have to go back and you release fluid from the side port. Now you see that once it is in the desired position, first thing you do is don't start tapping. Release fluid from the side port to shallow the chamber so that your tapping does not cause it to shift from its position. And once it is done, you can stabilize with one cannula, and the other one you can use to. And don't use violence. There is always gentle movements. And remember that, so unlike a DCI graft where you stroke on the surface on the graft to make it move, here you don't stroke on the surface. Stroking on the surface will be counterproductive because you move the fluid like that, then the fluid rebounds, and the rebound carries your graft in the opposite direction. So always go outside the graft and with the two cannula tap to create ripples, and then you will find that your graft will slowly move forward. This is again for a tight scroll in a young donor where the scroll is not opening up. You can use either this cannula which has two side ports. You can insert the you first orient the long axis of the cannula to your side port, and then you place the tip of the cannula inside the scroll, give a short burst of fluid. The side movement of the fluid opens up the scroll, and then you can just complete your surgery. Marking S stamp, we already know. The other options are creating a triangular notch or putting asymmetrical marks like the Roman numerals 1 and 2. When you mark it from the stromal side, when you join the two, 1 and 2, it should be clockwise. So that's one way, or you put a triangular notch like an arrow. If your correct orientation of the stromal side, the arrowhead should be going clockwise, not counterclockwise. This is again something to show you how to mark without doing a stromal punch, where you put a small air bubble in between the folded DM, and then you can dry the surface and you can just mark on the surface. The advantage of this is that you can use the stromal tissue for doing a dull tissue, for a dull surgery, because you have not created a stromal window. You can look at the orientation on intraop OCT as well. So that's in conclusion about insertion and unfolding. And I think this is what gives you a basic overview of doing Dmek, which is a very, very simple surgery. Dmek stands for definitely most easy keratoplasty.
New nomenclature by Rajesh, and thank you, Rajesh, for giving this wonderful. I always like your this innovative. Rajesh, please be seated.